Hey, thank you, Tapas, and thank you for putting together a great conference. And it's lovely to meet many of old friends and collaborators from all around the world. I'm very impressed with the panelists you got and the topics you're covering. So I'm looking forward to the whole conference. Before we get started, let me share my slides. And can you, Tapas, confirm that everyone can see it?
Yes, yes.
Good. As I said, it's close to midnight here, and it's a great topic to talk about pharmacokinetics. It can put anyone to sleep, especially if it's well past midnight. But I'll try my best to make sure it's as engaging and entertaining to you all. And I'm also pleased to talk to the nephrologists because they understand pharmacokinetics better than many others. Of course, intensivists do well too. So I would love to hear your views on this complex topic. Of course, we struggle to dose our patients just with kidney injury and while on renal replacement. When you add ECMO to it, things get pretty complicated. But in the next 30 minutes or so, I will try and kind of demystify some of these things and deconstruct and provide some practical guidance as to how we can approach drug dosing in this complex patient population. And I'm also very thankful to all the participants who took out their time to join us tonight. I should say, I just returned from a nice holiday in India and wish I was there in person, purpose to meet you all. So before we get started, as I said, drug dosing in intensive care is a very complex problem. We don't know what the morbidity associated with suboptimal dosing actually is. We think there is substantial therapeutic failure that can happen in ICUs due to inadequate dosing. But when we have ECMO, renal replacement, or any other extracorporeal therapies combined with critical illness, it's really a nightmare for the pharmacist or any treating physician who is trying to modify the disease using disease modifying drugs. And we know critical illness is like a raging fire. The whole body is going through a lot of systemic inflammation. There's organ failures. There is huge fluid shifts associated with critical illness. So most of our drug studies or pharmacotherapeutics that have been developed in healthy volunteers or not so sick patients. So when we directly transfer that knowledge to critically ill patients, there is a huge challenge to ensure our drug dosing strategies are optimal. The question we really have is, if critical illness has got such profound impact on pharmacokinetics, does adding ECMO or renal replacement to it make it substantially worse? If so, what are the implications of it and how we can make our dosing strategies better? And looking at the future, we can look at other opportunities we may have in research as well as in clinical practice to improve these dosing strategies. So it all comes down to understanding the interactions between the disease, drugs, and the devices we use in intensive care. The age-old pharmacodynamic, pharmacokinetic description of absorption, metabolism, distribution, excretion. That's fairly a simplistic model. It applies to people who are taking tablets in the community, but when we directly apply those in critically ill, we run into problems. And that's what we're trying to deconstruct here. So how do we get to the bottom of this complex dosing challenge, especially when we add ECMO, critical illness, and renal replacement? I think there's a lot to learn. And in the next 20 minutes or so, I will try and explain to you what we have done to understand this problem better over the last 15 years of research, many of which we did in Brisbane, and also try and come up with some solutions. So when we have a complex problem, the best way to approach it is to deconstruct it. This is the fashion these days. When you go and ask for a coffee, this is exactly what I got, and I was pleasantly surprised. So I had to make it up myself. So you get water, coffee, milk, all separate. You have to make it up on the spot. So this is called a deconstructed coffee, which is interesting. And in many ways, I prefer this to the prefabricated one. So similarly, we are going to deconstruct this complex problem. So what we know about critical illness and pharmacokinetics is that different drugs behave differently. And in a general sense, hydrophilic drugs is not just limited to antibiotics. Hydrophilic drugs have a lower volume of distribution naturally, and they are predominantly cleared by the kidneys. Lipophilic antibiotics, as we know, have higher volume of distributions, predominantly cleared by the liver, and generally have good intercellular penetration. In this setting, given these physiochemical properties these drugs have, when intensive care patients have altered organ functions and ongoing systemic inflammation, a lot can change. Predominantly for hydrophilic antibiotics, we see a big increase in volume of distribution, and clearance obviously depends uh, largely on renal function. And for all practical purposes in intensive care, this is the group of drugs we are mostly interested in because their dosing strategies can vary largely with varying renal function. And some of the examples you can see, some of the typical drugs are the beta lactams and the glycopeptides, whereas lipophilic ones, like the fluoroquinolones, they have they're a lot more permissive when it comes to margin of safety, or they allow you more leverage in terms of being lax with dosing strategies. And then we add ECMO to critical illness, few other things will change. Naturally, ECMO adds to the systemic inflammation that's already exists in the critically ill patients. Clearly, the fluid shifts associated with hemodilution that occurs with initiation of ECMO, more so in the pediatric patient population, can also significantly alter the volumes of distribution. And the most feared complication or consequence of ECMO is sequestration of drugs in the ECMO circuit. And of course, there are organ dysfunctions. The net result of all this in the end means there is significant changes in volume of distribution, which is generally an increase in volume of distribution, and typically a decrease in clearance, especially in those with organ dysfunction. So what are the consequences of this? The consequence generally is it leads to therapeutic failure. That means we're not optimally treating the condition we're trying to treat, or there may be misadventure causing toxicity and complications in patients. I think for most practical purposes, what we're interested is in therapeutic failure. As we know, ECMO or renal replacement for the matter, they're just supportive treatments and they keep the patient going till we fix the underlying problem. So unless we find ways to fix the underlying problem, we can't get these patients meaningfully out of these supports. So all of this led us to this ECMO PK project, and Ram knows much about it. This is something we undertook. This was part of my PhD. So we wanted to look at this problem in a very holistic way. And it was a huge amount of work done over 10 years with a large team of collaborators and friends and colleagues. And I'm very pleased to tell you that I got results for most of this, and I can present some of that to you tonight. So our journey began in 2009, just like COVID. We also we've forgotten the H1N1, but that's where really the ECMO revolution happened. I think Ram was in Brisbane around that time, and we started this journey. And around that time, when we started our ECMO cases, we were a few years into it, and we noticed some interesting things. The patients who were well sedated used to go on ECMO and then suddenly wake up, or needed very high doses of sedatives to keep them asleep. So which actually got me thinking. We thought, if at least sedatives we can titrate to what we see on the bedside, if this is what happens to the drugs, what about antibiotics? What about other vital disease modifying drugs? And that's what got us to this whole journey, and there were a whole experimental ECMO setup. I'm fortunate, and all of us who worked in this hospital are fortunate to work here, because we are not only a referral center for cardiothoracic disease, but also we have biomedical engineering lab, science lab, animal lab, all in one campus. So it allows us to, do the bench to bedside research, and ask relevant questions in the lab, ask relevant questions in the animal lab as well as the engineering lab. Also, bring back what we learn in the lab to the patients and conduct meaningful studies. So we're really privileged to be in this place. And also the lot of this research program was at that point run, and even now run, by the Critical Care Research Group under Professor Fraser, and which has grown to be one of the leading groups in the world. And I was privileged to co-head the group and run it for many years. So we developed many of animal models. We realized that when we started our ECMO journey, we realized we don't know anything about ECMO. ECMO was rarely used in the adults before H1N1, and suddenly there was a huge uptake in ECMO, and the outcomes were not as good, and we didn't know much about ECMO at all, especially in the adult world. So, of course, there were a lot of meaningful clinical studies going on around the world, and we decided to take a program of research also in the animal lab and also in on bench models. And we developed the ECMO models in sheep and pig, and also in our collaborators in other parts of the world also developed ECMO model in smaller rodents. We also developed a VA ECMO model, all of that with an intention to understand the altered physiology on ECMO, altered pharmacokinetics, altered various things that can go wrong once you put people on ECMO. And of course, no model is perfect. What we realize is that all models can be wrong, but some are useful. So with that spirit, we use these models meaningfully to get some answers. So to start with, we realize that it may be surprise to many of you when we reconstitute the drugs and keep them on the bedside. Already some of the drugs start to deteriorate. So when we do that with drugs like meropenem, for example, if a drug is reconstituted and left at the bedside and not administered quickly, drugs can actually degrade. And so we already on the back foot. We may not be administering what we think we are administering. So some drugs can be unstable even before they get into the human body once they are reconstituted. So then we did some ex vivo circuit studies. What we see there is the ECMO circuits that are primed with fresh whole human blood. And we put in a known quantity of the drug into these circuits, take some baseline measurements, and also see what happened to drug concentrations over a period of time. And these sort of studies are good to understand what exactly the circuit does to the drug in the absence of a patient. So we can't do this in real world, but it's as close to simulating it in an ex vivo circuit. It was interesting to us that even in the absence of the host or the patient, many of these drugs, especially if they were lipophilic, for example, fentanyl or midazolam, they were highly sequestered in the circuit. So, of course, we know that PVC tubing can have a high degree of affinity for lipophilic drugs, but it was a surprise to know that some of these drugs can be lost in the circuit to such a large extent. When it comes to antibiotics, once again, we saw that the vancomycin was relatively stable, whereas meropenem, there was some loss. And how much of that is degradation of the drug itself, how much is sequestration, we don't know. And this sort of started off the whole process. This was a stepwise approach we took. So after testing stability in the controls, we tested them in an ex vivo circuit. And with that data, we also found out that after some modeling that not just lipophilic drugs, protein-bound drugs, for example, thiopental or caspofungin or ceftriaxone, they may be at a greater risk of sequestration in the ECMO circuit. And that was also the findings of this ex vivo study. And then we started to do these studies in animals because circuit experiments doesn't reflect real life. So this is our animal lab, and all these sheep are looked after very well. We treat them very kindly, and they undergo no suffering, and they're very euthanized at the end of the experiment. So these are PK studies in healthy sheep controls. So we put in a central line, give them some known quantities of medications, take some samples, and the sheep are running around all day, and we need to go and grab them to get some samples. Other than that, they were fine. So that helped us do some modeling in healthy sheep controls. And then we bought the sheep next day and then put the healthy sheep on ECMO. As you can see there, the sheep is very comfortable, anesthetized on ECMO. It's a fully monitored setup, just like any other ICU. Of course, we can't do this in healthy human beings, and so we had to borrow the sheep. And we did the same thing. We took some baseline samples and gave known quantities of drugs to these sheep and worked out what happens to the volume of distributions and clearance once we place the sheep on ECMO. And comparing that with the baseline control sheep that were not on ECMO, it gave us good insights into the independent contributions of ECMO in the absence of critical illness. And then we took the next step incrementally and then put critically ill sheep. So these are our smoke lung injury models. And you can see on the left where we're inducing cotton wool smoke and the sheep undergoes smoke inhalation, gets severe ARDS. The sheep goes on ECMO. And clearly now we have a critically ill sheep placed on ECMO, and we did the pharmacokinetic modeling and sampling. And after administering a known quantity of drug to the sheep, there was a variety of antibiotics we administered so that we can opportunistically get data for as many drugs as possible while making sure there are no drug interactions. With all of that, what we figured out, I'm not going to detail of every drug here. I'm just summarizing what we found because we studied up to 12 drugs, I think antibiotics and sedatives combined. So what we largely found was that lipophilic drugs typically had increased volume of distribution. That was not a surprise, and that's what we see in critically ill. And especially if they were protein bound, the more protein bound they were, the lower the volume of distribution was. Similarly, when it comes to clearance, because the lipophilic drugs have a larger volume of distribution, they once again exhibited much decreased clearance compared to the hydrophilic or protein bound antibiotics, which generally tend to stay in the central compartment. So with the circuit experiments and these sheep data, one thing we could figure out was that if we knew the physicochemical properties of antimicrobials, we can actually predict their behavior during ECMO, during clinical ECMO. So this is going to be of relevance when I summarize and provide you guys with some practical advice towards the end. So far what we found is that circuit can sequester drugs. Equally, physicochemistry of the drug can help us predict how a drug will behave in an ECMO circuit. So that's what I meant. As I said, lipophilicity had very little impact on clearance, but definitely had a big impact on sequestration. So with this knowledge, we try to figure out, okay, what happens now? Because these sheep didn't go on renal replacement. Most of these sheep had some degree of kidney injury, but for all practical purposes had decent creatinine clearance. Also, I should emphasize this was only a 24-hour model of ECMO because it's very tiring to run prolonged models of ECMO in the animal lab because you need to sit there all the time. So we could only do a 24, 36-hour model. So we couldn't establish severe kidney injury along with lung injury in this model. So what I'll do now is to try and summarize what we know about pharmacokinetics and alterations in patients with kidney injury and how renal replacement therapy can impact drug dosing. So this is a nice review we recently wrote. I would recommend for the audience if they're interested to read. It summarizes the pharmacokinetic principles for in both renal replacement and on ECMO. So we just need to look at when it comes to renal replacement therapy and ECMO, obviously there are once again patient-specific factors. As we know, we discussed it before, critical illness increases the volume of distribution, decreases clearance. Of course, we need to be mindful of residual renal function. Compared to anuric patients, there will be some degree of clearance if the patient is not absolutely in anuric or completely in renal failure. And obviously, free drug concentrations are the ones that are relevant. Free drugs are the ones that get eliminated to the kidneys. So clearly, plasma protein plays a big role. For a given degree of renal failure, we also need to be mindful that plasma proteins play a big role in terms of drug concentrations in the plasma. And then there are drug-specific factors, whether how soluble the drugs are, whether they are hydrophilic or lipophilic, the molecular weight of the drug, the protein binding capacity of the drug, and the electrical charges, etc. So by and large, there are some drug-specific factors too, especially of relevance to renal replacement therapy is the drug size, the molecular weight. We'll get to that in a minute. And then there are some renal replacement therapy modality related factors because we know these days that, I don't know about you guys, in my unit, we at least have 5 different types of dialysis machines. So it's not easy to figure out, how to dose these patients. It's just like if one is not enough. So clearly, we not only have to factor in a sick person being on ECMO, then we also need to factor in the type of dialysis treatment they're receiving. It could be continuous renal replacement, it could be intermittent dialysis, or low efficiency dialysis. So once again, understanding the mode of dialysis and the dose of not just the dialysis and effluent flow, but also about the filtration rates. All of these are important when it comes to drug dosing. And of course, I'm not going to enlighten the nephrology audience about kidney or renal replacement, so I'll skip this. I'm sure they are well familiar with all this. So to summarize the renal replacement and renal injury and its effects on pharmacokinetics, as I mentioned earlier, different modalities of dialysis have different effects on pharmacokinetics. One thing for sure, the drugs with a large volume of distribution are not very well cleared by renal replacement. So drugs with higher protein binding also have poor clearance, because in the end, it's the unbound free fraction that is cleared by renal replacement. So that has to be kept in mind. Also, we need to keep in mind there may be some drug loss due to membrane absorption, even in the renal replacement therapy circuits, but there may be saturation points. It doesn't mean that the circuits continue to sequester drugs. There comes a saturation point where beyond which there is no more binding. So as we know, most drugs, which are less than 2000 Daltons, are to some extent removed by continuous venous hemodiafiltration, but they are larger molecules. When it comes to intermittent hemodialysis, we know only the smaller molecules get cleared. So we need to keep that in mind as well when we consider drug dosing strategies. Typically, as we know, larger molecules of vancomycin, oriconazole, etc., may not even be cleared by hemodialysis. So now that we know what happens roughly in critical illness, what happens when a critically ill patient is on ECMO, and what happens during renal replacement therapies, we tried to combine all of that and figure out what could be the combined impact of critical illness, ECMO, and renal replacement on pharmacodynamics and pharmacokinetics. So this is the site we all dread, and so we got a patient with septic shock, with very high cardiac output state, but still in shock with peripheral necrosis. They're on renal replacement, they're on high flow ECMO support. Each one of those components, critical illness, renal replacement, and ECMO, are playing their part in altering the pharmacokinetics and pharmacodynamics. And how do we ensure in such a patient the dosing of drugs or the doses of drugs we're using are optimal and get us the desired effect? So although we had a lot of information, what it came down to is, we sometimes, when you have a lot of noise, it's not worth pursuing what is not of importance. But the whole idea of research is to figure out what is important. So we realized that these individual effects of either critical illness or renal replacement or ECMO may not be that relevant. It's the combined effect that may be more relevant. And what we found also was that there is a cancelling effect. So if ECMO can increase volume of distribution for some drugs, critical illness on one hand can decrease the distribution for those drugs. But similarly, there could be cancelling effect on clearance. So we also found that drug physicochemistry is far more critical in that setting when the other effects cancel each other. And equally, the type of renal replacement we're providing is also a significant contributor. So for example, if you got a highly protein-bound, highly lipophilic drug like midazolam, it is going to behave quite differently to a hydrophilic but protein-bound drug like ceftriaxone. For example, midazolam will have a very high volume of distribution compared to ceftriaxone. So ceftriaxone will be far better cleared by renal replacement compared to midazolam, because there'll be a lot more unbound ceftriaxone circulating in the plasma, allowing for more clearance. So applying the same logic, if you have a very less protein-bound drug, for example, less than 10%, metoprolol is an example, but it's relatively lipophilic. So naturally, once again, it will have a higher volume of distribution compared to gentamicin, which is also less protein bound, but it's very hydrophilic. So it is more likely to be cleared by renal replacement and more likely to be impacted by renal function. Once again, these are some of the concepts we know in general critically ill patients who are not on ECMO. And my point here is that the similar logic and principles can be applied to patients on ECMO as well. So this is the sort of a summary of how lipophilicity, hydrophilicity, and protein binding affects patients on who are just critically unwell or who may or may not be on ECMO and may or may not be on renal replacement. This table essentially summarizes what I told so far, so I'm not going to go through it in detail. But when we did all this is all fine to do circuit experiments, put sheep on ECMO, and also look at available data in patients on renal replacement therapy. But in the end, all of that has to come together. So there is no substitute to doing population pharmacokinetic studies in the real world. And that's what we did. And in 2012, we designed this. I think ours was the world's first ever multi-center clinical study designed on ECMO. This was even before the EOLIA was published. So this was once again an international study we put together, and we decided to study 18 drugs, which included 12 antibiotics and 6 sedatives. And I'm very happy to say that we now have results for all of these studies, and we have data to guide us. During this study, we took pharmacokinetic samples from over 200 patients from all over the world, and there were multiple occasions of sampling for several drugs. But one thing that was sure, sorry, it's a busy slide. I'm not going to go through each graph, but generally, for practical purposes, to get the message across, the shaded areas represent areas where the patients who had optimal drug concentrations. So if you see cross or bubbles or any other shapes outside the shaded area, you just assume that these are the patients who are receiving suboptimal or patients who had suboptimal concentrations of the drug in the blood. So these are the drugs there, piperacillin, vancomycin, etc. So there are some drugs where, like drugs like fluconazole, we did very well with the current dosing regimes. Whereas there were drugs like vancomycin, despite having therapeutic drug monitoring, we were a bit all over the place. So this slide just highlights how complex this population is and how often we get our dosing wrong. Once again, this is the similar story for some other drugs. I'm not going to go through each one of them, but the message there is that, even with all the TDM for many of the drugs, even with all the knowledge we have currently, many of our patients are still not receiving optimal dosing. And we continue those clinical studies, and this was an interesting study that highlights what happens when you combine ECMO and renal replacement in critically unwell patients. And we studied meropenem I think it was 20 patients, and we had matched controls who were critically unwell and were not on ECMO. And we also used dosing simulations. I'll talk a bit more about simulations in a minute. So what we found was, and then we have on the right-hand side in each graph, we have those varying creatinine clearances. So what we realized was across a range of creatinine clearance, when we're targeting a MIC of around 2 milligrams per liter, our current dosing strategies were optimal. But if you're treating a resistant bug and we needed much higher MICs, which could be 4 times, for example, when you're targeting 8 milligrams per liter, most of the standard dosing regimes were inadequate. So it's more of a question of having awareness about your local microbiological flora, having knowledge of the local antibiograms, which is more of relevance when it comes to dosing, especially meropenem in this context, rather than absolute MICs. So standard dosing regimes should be sufficient, but if you're dealing with a bug that's highly resistant, please use higher doses. And then we continued these experiments with dosing simulations. For example, this was ceftriaxone. Once again, what we found was standard dosing regimes, what we currently do, were sufficient across most patients. So we didn't have to do anything different in ECMO patients. So we can continue to dose them based on what we currently do. Same was the case with piperacillin and tazobactam. Once again, what we found was that due to the cancelling effect RRT, ECMO, and critical illness can have on volume of distribution and clearance, the net result is that, once again, what we normally do in critically ill patients is what we should be doing in patients on ECMO as well. That's the same piperacillin. And this was the same story with ciprofloxacin as well. Ciprofloxacin, as we know, is interesting. It's got a greater volume of distribution. It's a lipophilic drug. And despite that, we also found that the current dosing regimes we follow in critically ill patients should be sufficient in patients on ECMO and RRT. And similar was the story with vancomycin. And thankfully, with vancomycin, as we know, we have therapeutic drug monitoring, which makes things a bit easier. So, how do we dose the drugs then? So, having a knowledge about physicochemistry, as I said, is very important. I would suggest having a chart for common drugs in your unit to understand their degree of protein binding and lipophilicity. That often is very helpful. Or these days, we can look them up on the phone. Having a basic understanding of pharmacokinetic, pharmacodynamic principles is important too. And clearly, we need population PK data like the studies we did. They give the most clear dosing recommendations. For sedatives, things are relatively easy because we titrate the sedatives to clinical effect. And therapeutic drug monitoring, where possible, is very helpful. At the moment where I practice, we do have therapeutic drug monitoring for beta lactams, and which is quite helpful, I think. So these are the common pharmacodynamic, pharmacokinetic principles. As I said, there are broadly three classes of drugs, as we know, when it comes to their mechanism of effect. It either can be concentration dependent or based on area under the curve, and some are time dependent. These are some fundamental things we all know about. Once again, knowing how your drug exerts its clinical effect, what class of drug it is, and what ECMO and RRT does to those drugs and drug behavior, all of that knowledge will help us individualize dosing in patients. And a word of caution on vancomycin. This is one of the studies, observational studies we did. Even though we have therapeutic drug monitoring, I'm very sad to say this is data from our own unit, so it's not something I can proudly present. But all I can say is that despite having therapeutic drug monitoring, we still get it wrong most of the time. So we need to be a lot more vigilant. And one of the things we have done is to move to vancomycin infusions. And I would love to hear what the panelists say and rest of the audience says, because we seem to find that we get more control on plasma concentration with infusions. So what I can say is that independent effect of ECMO on an antibodies, particularly in the end, is not clinically relevant. So we went through a period when we started doing ECMO during especially H1N1, that we were really worried that ECMO may have very nasty effects on pharmacokinetics and we may have to radically change our drug dosing. And I'm very assured with all the data we've seen through our research and some of the other research that's come out, I think the independent effect of ECMO on pharmacokinetics, especially of antibiotics, is not clinically meaningful or relevant. We definitely learned that knowing drug chemistry can help us choose the drug. For example, if I have to choose between morphine and fentanyl, I may prefer morphine, but that's purely based on circuit sequestration and pharmacokinetics. But we may also have to keep other things in mind, like active metabolites, etc., when we choose a drug. And context is also very important, because it's in the end, it's not just about PK/PD. I think sometimes we over obsess about PK/PD, and I'm not saying that's not important; it's fundamental, but we have to be careful not to miss the usual basics. So recommendations for lipophilic drugs are that if it's a highly protein bound drug and also lipophilic, then almost certainly we have to give a higher loading dose. Example, ciprofloxacin. For less protein bound drugs, then use usual doses, because the volume of distribution is not that high. And also always consider active metabolites. Similarly, for hydrophilic drugs, you have to balance protein binding and renal function. If the plasma proteins are good, then the free drug concentration is likely to be less. You can indulge in slightly higher doses. But if they have higher protein bonding, that's why a standard loading dose and frequency will be enough. But if they're less protein bound, we may have to use standard or slightly higher doses, because there is more free drug in the plasma. And especially if the renal functions are acceptable, they may have higher clearance. And also we know the phenomena of augmented renal clearance, which is a real thing, especially in patients with high cardiac output states and stable renal function. So to summarize, optimal drug therapy on ECMO is important to reverse underlying disease, to prevent complications, to provide comfort to our patients. But we need to keep in mind in the end that ECMO or any optimal dosing cannot compensate for poor patient selection, cannot compensate for poor ECMO process and poor quality of care. And this is what I meant when I meant context, because one of the questions I get phone calls midnight, someone asking, my patient's bleeding, should I change heparin to bivalirudin? And I may have got this question at least 200 times in the last 10 years from all parts of the world. And often you ask them, okay, what was your cannulation strategy? Now, thankfully, more and more units are moving on to a good percutaneous strategy. But once you had a generous cut down and put someone on ECMO and the patient's bleeding in the groin, changing heparin to bivalirudin is not going to do any magic. So it's not the pharmacokinetics that's failing here. It's actually our ECMO process. So that's why it's important that we optimize the basics of ECMO first before worrying about drug choices and pharmacokinetics. So this is what I meant in any good ECMO program, because just like Ram and many of us here are, we are very interested in ECMO process and ensuring high quality ECMO care around the world, whether it's through education or research. And I can't miss this opportunity to make this point, is that any good ECMO program is built on good organizational planning, staff training, credentialing, education, and quality assurance. Then on top of that, those are the absolute fundamentals. Then you select patients better, put them on ECMO at the right time, optimize our whole process, including process of cannulation, provide high quality ongoing care, wean them on time. Overstaying on ECMO is a big problem. So once again, that has a consequence for pharmacokinetics. And then comes all the blue sky stuff when we researchers do that, the magic circuit that has no complications will never come, but we need to refine our clinical application all the time. So there's a lot to fix with simple things before we worry about the bigger things. So all I can say is there is not much we need to worry about drug dosing in patients on ECMO or also happen to be on renal replacement. We can do what we normally do in critically ill patients and continue to dose them as usual and use therapeutic drug monitoring where possible. And all I would say in the end is that patient selection and process is the biggest determinant of outcome. Thank you.
Thank you, Kiran. That was an excellent talk. Clearly, you summarized your PhD in 40 minutes. Not an easy task to do that way too at 12 midnight. But all said and done, I mean, jokes apart, I should say that, people who have been listening to this talk, we clearly have more insights now from the kind of research you have done. I know I was there at Prince Charles when a lot of this work was going on, and clearly, this is great to listen to some of the findings that your studies have showed. Your presentation has been quite succinct and quite great that I've had about 19 to 20 questions pop up in the last 40 minutes. Now, before I open up the questions, a few of them are repeats. Before I come out with those questions and read it out for you, I'll open this session to the comments of the panel members. So panel members, Flavio, Sanjay, and others, any comments on what Kiran said, or any personal experiences that you would like to share? Kiran did bring up certain aspects like vancomycin infusion as an alternative way of administering drugs when you have ECMO and RRT. So yeah, I'd like to listen to the panel members first before I bring up the questions, Kiran.
Thank you, Ramanathan. Kiran, of course, you've been at the forefront of this topic, and most of us have referred to the articles that you've written over the years to gain insights into this particular topic. And so I would like to share that in our institution, of course, we prefer to use vancomycin infusion. So is the case with prolonged beta-lactam infusions, especially in these patients. So of course, so one of the topics that keeps coming is, the lack of therapeutic drug monitoring, and a lot of practitioners of ECMO, when they send these tests, they don't either it takes a long time to get those results back. But then you, of course, summarized it really well in the end that for most patients, your usual dosing will get you through. And but then I was reading your article, and I was intrigued by the newer software-based and the AI-based dosing regimen that you're trying to develop. Uh, do you have any further updates from there as to how you're taking it further, and if anything positive is coming out of it, and for us elsewhere to utilize that asset?
Yes, that's a great question, and thank you for the compliments. Look, yeah, there are two things related to that. Yes, we did two things. One was the dosing software is interesting because this is what I meant. When you have dosing simulations, there is enough technology now to use simulations and AI to predict dosing. So that is inevitable, that will come. What we did was we tried to have rapid diagnostics combined with dosing software. Like, imagine if someone's got sepsis, if you can have a rapid PCR technique that on the bedside can tell you what the bug is, and then also the dosing software tells you what the right dose of the antibiotic is. That is nirvana, right? So, but it wasn't as easy. What we found was with rapid diagnostics, there is so much noise. The PCR will pick up all kinds of noises, lots of bugs which are relevant. So that didn't work. We're optimizing that. But the dosing software seems to result in better dosing. And as AI would eventually show, the doctors are not very good with a lot of things, probably including drug dosing, but now we can say that in an audience full of doctors anyway. No one else is watching us. But so yes, dosing software could be helpful. So I think that is the exciting part that we are looking forward to. Yes. And other thing I'm very excited about is the point of care. Like, we don't need a quantitative test. If like the pregnancy test or just a simple qualitative test in a strip to ensure the drug concentrations are optimal, it could be a good point of care testing technique, which we're trying to work on. But once again, it's not easy. When you start working on it, it takes a lot of effort.
I'm sure Srinivas will be adding in a lot about artificial intelligence and all these aspects in his next talk. Dr. Ranajit, I saw you raising your hand earlier on.
Yeah.
Any comments from your side, Dr. Ranajit?
So, first of all, I like to congratulate Kiran, and I'm quite jealous about you wearing just a shirt out there. And we are basically in cold. We are just reeling in cold out there in Delhi. It's 2 degrees centigrade out here, and with Indians, so 2 degrees centigrade is quite low temperature. In Australia, you are much better out there. And I congratulate you for your beautiful work that you have shown. And the most important part is to convert this research into clinical practice. As clinicians, when we are using CRRT for the last 12, 13 years that I'm using, maybe 14 years or so, what I've understood, the use of antibiotics, whatever you go for therapeutic drug monitoring, you may not get everywhere. Creatinine clearance, again, it's maybe elusive. And it is a dynamic process, Suppose you have started with CVVD, CVVHD. There, the antibiotic dosing will change completely when you come to a situation of CVVH, if you increase the ultrafiltration, or we are going for CVVHDN. So this is a dynamic process. As we have truly said, that we can't titrate antibiotics. We can titrate on our vasopressors, we can titrate on the sedatives. So that is the reason why it becomes more difficult for us to select exactly what antibiotics at what dose to use. Regarding vancomycin, if you ask me, we do not use vancomycin in patients who are already having AKI. We try to avoid vancomycin and aminoglycosides in this type of patients because we already know that these are already obligatory nephrotoxins. So we avoid it in my center. I use the other drugs if I get the cultures. And Also, if I am going for a high ultrafiltration, if my filtration fraction is increasing more than 25%, definitely I'll increase my maintenance dose. I never, as you have already said, will compromise with my loading dose. Sometimes I have to increase it somewhere. And again, with CVD HDF, when I'm going to it, I have to increase my antibiotic doses at least by 10 to 15% when I'm going for the maintenance dose. I always try to assimilate with the cultures, with my procalcitonin levels, and try to come into a common conclusion. But it's tell me, I'm still elusive exactly what should be the correct antibiotic dose. I think if you come up with a software, will really be beneficial. Again, thank you. Beautiful, very good research work that you are doing for the last 10 years. We have benefited for it. When it will be converted into clinical practice, I think the patients will be benefited. Thank you so much.
Thanks, Dr.
Thank you, Ranjit. Thank you.
Dr. Lobo, any questions or any comments from your side?
Yeah, the only comment was because I think I saw one of the questions in the chat box also mention, is there a difference of vancomycin dosing when you're talking about intermittent and CRRT? Now, in the many of the nephrologists liked vancomycin in the old days because it looked very simple. 1 gram once in 7 days as maintenance. But those were based on studies in the 1990s when the dialyzers were different, the machines were different. And when we started getting therapeutic drug monitoring and we started doing SLED, and we looked at vancomycin levels in SLED, and we found that we were getting therapeutic levels in only about 25% of the levels that we checked with the dosing that was earlier recommended. So we had to modify, and we found that after 2 SLED sessions, there was no alternative but to do a therapeutic drug monitoring. And very fortunately, we were able to, with vancomycin, we would get vancomycin levels within 4 hours of sending it, which is very significant actually for therapies like SLED, because when during the time the patient is on SLED, he's clearing the drug. When he's off the SLED, he's not clearing it. So you can't wait too long. With CRRT, at least you have a fairly constant clearance happening, and it may not make too much of a difference. But you can't have a drug level which is relevant, say, at this time, if the report is going to come tomorrow morning. So therapeutic drug monitoring is almost invaluable. And yes, we also have started using vancomycin infusions now. And after every 2 SLED sessions, it's mandatory, if not more often, to do drug levels with drugs like vancomycin. Now we're doing it for colistin also.
Thanks, Dr. Lobo. Flavio, any comments from your side?
Congratulations for the outstanding talk. It was really very good. I have a question for everybody. In addition to vancomycin, can you, in your countries, check the concentration of any other antibiotic?
Yes. In our hospital, we get posaconazole, amphotericin, aminoglycosides, colistin, anti-epileptic drugs, cyclosporin, tacrolimus, and digoxin.
Great. While we listened to some of the comments of the panelists, I take 1 or 2 questions and pose that to Kiran. Kiran, a few of those questions are repeat, but one question that caught my attention, it's a question from someone in Indonesia as to how you would choose, exclude, or substitute sedative agents when you use ECMO and RRT. I think the question essentially means what would be the ideal sedative agent you use when you have ECMO and RRT together?
Yeah, that's a great question. And who was it, Ram? Is it someone from Indonesia? Is it okay?
Yeah, it is.
Thank you so much for that question. And yes, I focus more on antimicrobials because sedatives, thankfully, are titrable, and it would lengthen my talk. So I wouldn't focus much on sedatives. With sedatives, I've got a few things to say because it's a very passionate area of mine. And once again, I would say, like I showed you the pyramid where the priorities, if you're a new ECMO program focused on getting a patient safely on ECMO, completing the ECMO run safely and getting them off, don't get too fixated on the sedative choice. sedation is a culture in the unit, and how we sedate patients and what strategies we apply depends on availability of the drugs. Many parts of the world, we don't have every drug available, and also about what you're comfortable with. So from first principles, obviously, we use as little sedation as possible. That's what we do in our unit. And I don't say a new ECMO program, we should just stop all sedation all of a sudden. It takes a bit of time to get comfortable. So there is a context, that's what I meant. Your intention to sedate is important, how deeply you want to sedate the patient. Generally, the field is moving towards having patients less and less sedated and more ambulatory, and at least doing some rehabilitation in bed. So that context matters. And outside that, then there is a question of drug choice. The drug choice, as I said, is better go for less lipophilic drugs. Like midazolam in best of times is not a great drug, even outside ECMO. So if you can avoid midazolam, that's good. We can also use, we use a lot of dexmedetomidine. I know it's only approved for shorter term use, but there are multiple benefits of dexmedetomidine, especially on VV ECMO. We drop the cardiac output, that reduces the dependence on ECMO blood flows. It also gives good anxiolysis and comfort to the patient. So we usually use a cocktail. We generally try and not overdo any one drug. We typically use a low dose opioid, even though our data shows morphine, we still tend to use fentanyl for other reasons. There's low dose fentanyl. Typically, there is some dexmedetomidine in the mix. And also, if they're in the later stages of the run, we may add even low dose ketamine. In the first few days, we use propofol if the hemodynamics allow. I would prefer propofol to midazolam. Propofol is safe in the ECMO circuit. Once upon a time, there was a concern that it can clog the circuit, but that's not the case. Propofol can be safely used on ECMO. And then in the later stages of the run, we tend to use more enteral medications as well, especially if they've been on higher dose of opioids. We then tend to introduce some methadone. Then we also can use oral benzodiazepines, enteral benzodiazepines, clonidine. So we generally use a multimodal strategy rather than overdoing any one drug. Hopefully that answers your question.
Yeah, I agree with Kiran wholeheartedly, and that has been our practice here as well. And we tend to avoid benzodiazepines as much as possible. If we have to really sedate in the initial phases, like you mentioned, propofol is the one we go with for the most part. We also have some antipsychotics in the mix, in addition to the other medications that you already mentioned.
Yeah. So, thanks, Kiran. Thanks, Sanjay. In fact, in the process of answering that question, Kiran, you answered Saikat's question on dexmedetomidine as well. Well, I think, I'd let you go through those questions, Kiran, and maybe reply them on the chat if possible, while I move on to the next speaker.